thanking the organizers, especially my very old friend, Dr. Alok Kanungo, for having invited me for this year's meeting and to make a presentation on gestational diabetes, post-delivery outcomes.
Please mute yourself, except the speaker. Others, please be.
The plan of my presentation today will be talking briefly about postpartum hyperglycemia, conversion to diabetes, depending on how the GDM was diagnosed, whether we use Carpenter-Couston criteria or the IAD-PSG criteria, and then taking you directly to results from our study called Living, in which we looked at a sort of a real-life implementation of a lifestyle intervention to see if we can retard or prevent this progression to type 2 diabetes. Now, the audience would be very familiar with the fact that the overall risk for type 2 diabetes is about 10 times higher in women with previous gestational diabetes as compared to healthy controls. And this is a systematic review which was published a couple of years ago. These are data from a multi-ethnic study done in Canada, and you can see that the conversion of GDM to postpartum diabetes was compared between South Asians, Chinese, and whites. And not only was the prevalence of GDM higher in South Asians, the likelihood of progressing to type 2 diabetes was also the highest among South Asians when compared to the other ethnic groups. What about data from India? Now, these are data in which the Carpenter-Couston criteria was used. The first couple of studies, one from Dr. Kale and colleagues in Pune, showed that over a mean postpartum follow-up of about 4.5 years, 50% of the women who had GDM had moved on to develop diabetes. And another a smaller study from Mysore, again showing that a 5-year period, about 1 in 3 of these women moved on to diabetes. We went on to do a similar study in which we evaluated the conversion of GDM to future A1C and the predictive value of HbA1c in an Indian cohort. This was published in 2016, and we'd use the Carpenter-Couston criteria to diagnose GDM. And the data from this study is the largest study done in India from this on just more than 350 people. At a median follow-up of 1.6 years, 1 in 3 had already progressed to diabetes. And in the group which had been followed up between 2 and 4 years, 50% had already gone on to develop diabetes. So again, showing that this is an extremely high risk group for disease progression. This is, again, to give you a sense that if you looked at these 366 women, at the end of the follow-up period, 32% had diabetes and another 40% had pre-diabetes. So actually only 1 in 4 women stayed in normal glucose tolerance if they had GDM when it was diagnosed using the Carpenter-Couston criteria. I've already mentioned to you that about 50% had diabetes after 2 to 4 years. And compared to an age-matched general population, these were data taken from the INDIAP study. If you had a woman between 20 and 29 years of age, there was an 18-fold excess risk. And when it was between 30 and 39 years, there was nearly a 10-fold excess risk. So clearly, this is a category of individuals who nearly need to be looked after. So a summary of this part, these were the highest reports ever reported in literature. Postpartum screening rates, unfortunately, were about 35%, suggesting that not all the women turn up for postpartum evaluation. Overweight and obesity became a significant part. If you compare the pre-pregnancy BMIs to the postpartum BMIs, there was a change of 4 kilograms per square meter at this point in time. And therefore, given the early conversion, any efforts to reduce development diabetes should become early. Subsequent to this study, the criteria all over the world started changing to IAD-PSG. In our cohort, when we use the Carpenter and Couston criteria, 70% of women were on insulin, whereas in the IAD-PSG diagnosed women, especially when you remove overt diabetes, only 20 or 30% women require insulin. So there were a handful of studies again done from India using the IAD-PSG criteria, and again showed one thing, that now, because you possibly ended up having a milder cohort of individuals, the diabetes conversion rates at a short term were lower, though dysglycemia rates were again between 20 and 30%. And except for one study from Chennai, which went up to 1 year, the rest of them were really very short duration studies. So this was another piece of work which we did, and it was long term, which is more than 1 year postpartum glucose tolerance status amongst women who'd been diagnosed with GDM using the IAD-PSG criteria. And you can see the difference out here. As opposed to about 28% women who were normoglycemic, this number increased to about 42%. Diabetes, which is about 32%, came down to 10%, but pre-diabetes was 47%. So overall dysglycemia was about 60%, despite identifying a cohort of women which perhaps had less severe disease than those identified by the Carpenter-Couston criteria, because with IAD-PSG, anybody with a fasting more than 126 and a post-load of more than 200 would be called overt diabetes and not called gestational diabetes. And again, the not surprising predictors of dysglycemia were insulin or oral agent use during pregnancy, first-degree relative having diabetes. The older the person, the longer the duration since the index delivery, the heavier the individual, and features of insulin resistance. Now, the important thing to understand is compared to the Harpo study, which led to the creation of the IAD-PCC criteria, our women were younger, and the median follow-up was much, much less, despite which the diabetes rates were very similar, suggesting that if we had longer follow-ups, I mean, this was 11 years from the Harpo study compared to under 2 years in our study, the conversion rate would be even higher. So we went on to evaluate the way we could try and prevent this progression by looking at a lifestyle intervention. I will not go into the details of the pilot study which we did, which was looking at the feasibility of this lifestyle intervention, which encouraged us to proceed. This is a protocol from the study, which was published in Diabetic Medicine, and the study was funded by the Global Alliance for Chronic Disease, a combination in our instance of the ICMR and the NHMRC Australia. So this is really the design of the study. It was an open label, parallel group, pragmatic, individually randomized control trial with a blinded endpoint adjudication. It was a very low intensity lifestyle modification program because we wanted to see whether such a low touch intervention, which could be easily adaptable to routine care, especially in low resource settings, would make a difference. We calculated that about 1,400 women would be required. We looked at 19 hospitals across 3 South Asian countries. And the primary outcome was a proportion of women with a change of glycemic category. That is, from normal glucose tolerance to either prediabetes or diabetes, and normal and prediabetes to diabetes. Secondary outcomes were changes in body weight, waist circumference, blood pressure, fasting glucose, physical activity level, and diet. And the inclusion criteria were very straightforward. Anybody who did not have diabetes between 3 and 18 months in their postpartum GTT, after having been diagnosed as GDM during pregnancy using the IAD-PSG criteria, were invited to participate. Anybody who had diabetes was clearly out. Anybody who lived far from the hospital, did not have a mobile telephone, and was likely to move residence in the next 3 years because we wanted a follow-up, were not included in the study. Now, this is a flow. Women were identified between 24 and 34 weeks of gestation, nearly 3,500 women, which is a large study. Eventually, only half of them, a little bit more than half of them, ended up coming for the postpartum GTT, which was 3 to 18 months later, again suggesting that there is a significant drop-off despite the fact that we had contacted these women during pregnancy and they had agreed that they will come back to us during the postpartum period. This then led to certain conditions which caused us to exclude them, and then they were randomized to intervention and control arm, 6 monthly follow-ups using a 75-gram GTT at the end of the study to categorize individual. We'd planned on 1,400 people, eventually ended up doing 1,600, which is the largest ever study done anywhere in the world. 70% of our patients came from public hospital, and the follow-up ranged from 1 to 3 years. So this was the intervention, very simple, very marginal, and very light touch. Group sessions, the 4 group sessions, initially at 3 weekly intervals, so first, second, and third were done by 6 weeks. This was then supplemented by 2 SMSs, either text or voice, depending on the preference of the participant, every week to reinforce the intervention, and a monthly phone call from the care coordinators, and a 4th session at 26 weeks. At the end of 6 months, we would then take a decision based on weight change, whether or not the trajectory we expected was being followed. And if it was not being followed, that is, if there had been no weight loss or there was weight gain, those individuals then converted into an intensification category in which 2 more individual sessions were done, while for the remainder, you continued with the 2 SMSs or voice messages and the monthly phone call. So this entire intervention lasted for 1 year, and the follow-up continued thereafter. So these are the baseline characteristics, and I just wanted to point out here that they were very well matched in terms of gravida, time since delivery, the prior history of GDM, insulin use, family history of diabetes, their BMIs, the waist circumferences, the hemoglobin A1C, the fasting glucose, and their glycemic status. As I mentioned, by the time they underwent the postpartum OGTT, and 9% of women already had diabetes, again suggesting this is a very rapid conversion happening, and therefore all interventions should really happen soon. 37% were pre-diabetes and 62% had normal glucose tolerance. The other thing which is important to understand is despite this being from South Asia and 70% of the population coming from public hospitals, 40% of women were overweight and 23% were obese. So 2 out of every 3 women was either overweight or obese. That's a very important finding. The results, unfortunately, were not encouraging. 1,308 participants, 81% had an end of study visit. And if you included women in whom we had an A1C on follow-up, that became 90%. Remember, the study was done right during the COVID epidemic, which led to problems. A lot of the sessions which were supposed to be face-to-face could not be done face-to-face, and we had to convert that into video sessions. And also the ability of the participants to participate in lifestyle modification, including physical activity, was significantly impacted, as was our ability to actually, monitor things as much as we'd done. So worsening of glycemic status happened in about 25% in the lifestyle intervention group and 27% in the usual care group. There was a trend towards benefit in the intervention arm, but this clearly did not meet statistical significance. So if you see the error, the confidence intervals, you see that they were clearly shifted towards a trend towards benefit. Pre-diabetes at baseline led to a 20% of them developing type 2 diabetes during the short follow-up period, suggesting that if in the postpartum GTT you have pre-diabetes, this would be an even more important subgroup to follow. This is again showing the same thing on a Kaplan-Meier plot, and you can see that there is no significant difference. And there was a significant follow-up, which is available till about 18 months after the study was initiated. So this and the secondary outcomes, whether it was development of diabetes, change in fasting glucose, change in body weight, waist circumference, blood pressure, etc., were again not different. So overall, there were trends towards benefit, but there was no clear benefit. So a summary of this: 1,600 women randomized to either usual care or lifestyle intervention. There was no significant difference in the proportion of study participants with change in glycemic category, though we are encouraged to see the direction in which this response was happening. And we look forward to be able to strengthen this, but we feel that there may be a reason or requirement to add oral agents in this form. So let me just wind up and say that the strength was this is the largest study ever conducted globally, very broad inclusion and limited exclusion criteria, which mirrors real life. So it was replicable in the real life. Extremely difficult study design and recruitment. And then unfortunately, like many things which happened in the last 2 years, the COVID-19 impacted. So let me conclude by saying, number one, that the risk of type 2 diabetes in women with prior GDM is nearly 10 times higher compared to healthy controls, even in our population. Very high conversion rates in Indian women, and that's happening even extremely soon after delivery. So any intervention, if you plan, must start very soon after delivery. There are multiple cardiometabolic abnormalities which are coexisting in this population, which I did not talk about. We need an intervention strategy to prevent or delay this. A light touch intervention alone may not be adequate. We may need to think of involving the family as a unit so that it's not just the woman who's participating in the intervention, but the entire family, and or use preventive drug therapies to facilitate that. Let me thank you. But before I do that, I'd like to put on record that this work was done in collaboration with several people. For the interest of time, I've not been able to name all my collaborators, both within the department, within AIIMS, but outside the department, and a whole bunch of principal investigators across 19 trial sites across 3 countries.